It's a pleasure to be here after many years. Thank you, Dr. Manya, for this invitation. Okay. So we are going to talk about children with HIV and transition to adulthood. Now, as we all know, pediatric HIV has almost stabilized. We hardly see, as Mamta said, that we hardly see any new perinatal HIV coming up or children born who are positive. So the problem that is now gone is that most of these children are becoming older, they're getting into adulthood, and they need to get transition to adult care. However, it's not so simple, the transition. It's not simple that the moment the child turns 18 and you said, oh, now you just go to the adult clinic. Because children are still mentally not tuned to be an adult. They still like to be cocooned. So there are problems with transition. The child emotionally is not able to adjust to the adult environment. A lot of times we tell them, you go to the adult ART center for the drugs, and they say, no, there's a big queue, they don't pay attention to us, we want to come here. So there are these issues which the child faces emotionally. They want to come to a protected clinic as compared to a busy OPD. And adolescent is an age where no matter what you do, they're just not going to take the drugs. So there are going to be adherence issues. They're just going to throw it out of the window no matter how much you counsel them, disclose, tell them about their status and all that. They just don't want to take the medicines. There are a lot of self-body issues. They have a lot of issues about their body structure, and they have personality issues. The moment they are exposed to the adult scenario, they get low esteem, and the most major thing, which Dr. Moti also highlighted, are the marriage issues, because they are in an environment where they don't know how to get married. So we'll see this first patient. She's a 25-year-old girl. Now this girl was actually from Mumbai, but she used to go to the US to take her treatment because they didn't want anybody in Mumbai to know that she was positive. So every 6 months she would go to the US to take her treatment. She was still under the pediatric care in the US. And now the pediatrician felt that because we have all these drugs now available in India, it's better that she's transitioned to India for her treatment. The problem was that her viral load was never undetectable, and she was on multiple combinations. She was on abacavir, lamivudine, lopinavir, ritonavir, and raltegravir at that time. And the patient was not ready to shift to an adult clinic, so they referred the child to me. When she came, she was extremely shy, and she had this lipodystrophy that you could make out. And on inquiring, when I took her into confidence and asked her, she said that she was not taking all the medicines that had been prescribed to her by her pediatric HIV specialist because she was unable to swallow the tablets and the large capsules. So she didn't even like to take calcium tablets. She preferred a calcium syrup. So though she was 25 years old, mentally she had not grown to that age of 25. And she had not disclosed this thing to her previous pediatrician. So I asked her, if I shift you to 1 pill a day, will you take the medicine? So she said she's not going to be able to swallow it. Okay, shall we pulverize it and give it to you? And then she agreed. So the solution was we stopped everything else that she was on. We put her on one drug, and we told her to pulverize the tablet, and she started taking it, and after 6 months her viral load was undetectable. So we assume that these children, when they grow adults, they will be able to take adult formulations, or they won't have any problems with the pills adherence, but it's not the case. So what is the key message here from this case is that young adults are still uncomfortable talking about their problems to the physician. There are still a lot of psychological issues, there are still adherence problems, and they like to talk to pediatricians as compared to the physician. So there has to be a transition in place. We just can't say, okay, start going to the adult physician. So there is a need of an hour where I think our country can take up this, that we should have these transition clinics where you have a pediatrician, you have a physician, for any disease for that matter, sitting together and slowly transitioning the patient out from the transition clinic to the adult clinic. Let's take this patient. Now this was 9-year-old. He was referred to the HIV clinic for treatment. Those days we used to use zidovudine, lamivudine and efavirenz combination. After 10 years, we shifted him to tenofovir, lamivudine and dolutegravir. He had an undetectable viral load. Now this patient is 23 years old. He still likes to come back to us, and he's working in a bank. The issues are, he wants to get married. He's not found somebody as yet. They are planning to go for an arranged marriage. He hardly has any friends because none of his friends will understand his disease is what he feels. He wants to go abroad for further studies, but he always comes back and discusses, in the visa form, will I have to disclose that I'm positive? So that's his major issue. Whenever he decides that he wants to go to the US for further studies, what about the visa issues? The parents were positive, they knew the child is positive, they were looking around for him, and suddenly one marriage proposal came. The girl was negative. Now the problem that the parents and the family faced was, how do we disclose to the girl and the family about the boy's status? So the boy went and disclosed to the girl about his status, and the proposal just fell apart. It just didn't work out. The problem that occurred is, now the boy doesn't want to get married. You tell him to go to support groups, talk to other PLHAs. No, he just doesn't want to get married. And he just doesn't want to talk about his status to anybody else. So what Dr. Moti did, I think, was a very wonderful thing, where he called all over the state and he had this kind of marriage proposals that came out, because this is a major issue which all transitioning patients are getting about it. So one of the other issues that these patients feel is the marriage issue, the peer isolation that they feel, the disclosure status, and the stigma which is still associated with the disease. Though it's a chronic manageable disease now, it's still got a lot of stigma. I still remember the time, Mamta was also there in the OPD. There was one patient who just came in, the father just came in and hid under the table while we were doing the OPD. And we said, what happened? He said, no, I'm positive. There's an MR standing outside. He's my neighbor. He doesn't know I'm positive. So he just hid under the table. I'm sure Mamta remembers that. So there is still a lot of stigma that is attached with this disease. And adolescents, when they are transitioning, for them, the stigma enlarges. Everything enlarges in that period. So you feel everybody's looking at you when no one's looking at you. And you feel that everyone's discussing about you when no one's discussing about you. So everything's enlarged at that age. Now let's talk about orphans. Okay, we at Wadia have a lot of orphanages who used to follow up with us. And these are kids who don't have parents, or maybe they have a single parent, and they're staying in an orphanage and they're transitioning to adulthood. What happens to these kids is, these orphanages keep them till they are 18 years of age in the orphanage. After that, they are on their own. So most of them, 2 or 3 of them, rent out an apartment, stay together, and then they look for jobs, or they are studying in the college. So suddenly at 18 years, they are on their own. Till the time they were in the orphanage, they were being looked after by the orphanage people. There was an environment that they were there in. And suddenly at 18 months, they are in their this thing. But the resilience in these orphans is much more, because right from childhood, they've been staying alone without parents. So their emotional resilience is much more as compared to HIV-infected kids who are with families. So their resilience is much more. The issues which these orphans face is the marriage issue, again, because they have nobody to turn to for their marriages. A lot of orphanages do arrange their marriages. We have one from Andheri where these kids are, the orphanages look for marriage proposals for them. And suddenly the health issues comes. We've had kids from the orphanages who've thrown out their pills out of the window, even knowing that they have HIV cardiomyopathy or, those health issues. Because suddenly till now the caretaker in the orphanage used to give them the medicine. And suddenly now they have to take the pill on their own. So the health issues that they have, they're responsible for their own. And sometimes because they are lacking the love, the emotional love, if you ever visit an orphanage, you'll see how these kids cling to you. Because they are just so much emotionally deprived of love, that sometimes in that search for love, they land up behaving in a reckless manner. So these are the specific issues which an orphan would be facing. Let's take this case. Now this was a 5-year-old boy, TB with HIV, went on anti-TB treatment, ART, became asymptomatic. Currently, this child is 23 years old. He's on tenofovir, lamivudine, and dolutegravir. Viral load is undetectable. Parents are on ART from an adult physician in another town. He refuses to go back to the adult physician. We are telling him, you go to the adult physician. No, I want to continue coming here. So he comes all the way from another town to, every 6 months. He's doing engineering in another town. He stays in a hostel. He's in a serious relationship with an HIV negative girl. He has disclosed his status to the girl and both are serious about marriage. So very few will find somebody like this where they are ready to go into a relationship and marriage. Now the problems that they face is should the girl go on prophylactic ARV? And they're discussing marriage, so they're discussing pregnancy. So discordance is a problem, and then they are facing how do they go about, should they go for artificial insemination? Should they go in for, so those are the various issues now that they are facing. And they're coming on their own. Both the boy and the girl come on their own. The parents are not coming. They're coming, but they don't want to go to the adult physician as yet. So there is a need for these kind of transition clinics. So there are going to be relationship issues in these. So the first thing that you tell the girl, are you careful? Are you doing your HIV test every 6 months? Be careful when you are in a relationship because we don't want you getting HIV. Are you sure you don't want to take PrEP? All those things come into the picture. So the conclusion is transition to adult health system for any disease is a delicate step. There may be disruptions to care leading to drug resistance, and compassionate and family-centered transition programs are the need of the hour. So I think transitional clinics should now be coming into practice with physician and pediatrician, involve a psychologist, so that these youth can become mature adults and responsible adults. We don't want them suffering like this with stigma, isolation, trauma, lack of support, suicidal tendencies. We want them to hold hands together and walk together. Thank you very much.